All right, thank you very much, Dr. Erickson. I appreciate it. And I want to thank our previous presenters. I learned a lot this morning and appreciate getting a little bit of movement as well before talking to you all. It's an honor to be here. I really am grateful for the opportunity to share some of my experiences with you. More importantly, to share what psychiatry can do for patients going through cancer diagnoses, treatment, and remission. As you see on my first slide, those are the three sort of phases of patients that I get the opportunity to work with. So I will discuss each of those in a little bit of detail. Dr. Erickson has been a great collaborator, and I appreciate the introduction there. The referrals I oftentimes get are from primary care, but also from oncology. A little bit about the beginning of the treatment that we had here. This opportunity for me began in 2016. Dr. Rekha Chaudhry, a neuro-oncologist, and I were friends outside of being physicians. And she shared with me, you know, the idea of having a psychiatrist with my patients would be really wonderful. We worked hard to see if we could bring this together. And we began work in September of 2016 in her clinic up in Westchester. Initially, I was just seeing patients of hers who had diagnosed with glioblastoma multiforme. In the intervening months and years, I have been able to work with patients from a variety of oncologists, a variety of diagnoses, and so I basically am able to take all comers. Back to the three phases here. I'm going to talk first a little bit about the patients that I meet who are newly diagnosed. The adjustment in a new diagnosis, a new cancer diagnosis, is, as you might imagine, very difficult. Patients have a lot of questions, patients have a lot of fear, patients have a lot of concerns. I will then go ahead and talk about patients that I meet for the first time who are actually already in treatment, and then I will talk a bit about patients I meet who have actually gone through the cancer treatment process and are in remission. And each of these patients, each of these groups of patients present interesting challenges and opportunities. One of the benefits of having a psychiatrist on the treatment team is that I'm a medical doctor. I've gone through training, medical training, but I'm not in cahoots necessarily with the oncologist in terms of fighting the cancer. My job is initially to listen and to see where the patient is. Patients, as you might imagine, are diagnosed at different ages, come with different questions, different sets of fears and hopes in terms of their cancer. I get to meet patients for the first time for a 60-minute initial visit. And for a patient to have a 60 minutes with a doctor can be quite a good span of time. I do follow-up visits that are anywhere from 30 to 60 minutes, depending on patient's needs, and the frequency of those follow-ups can vary, of course, from patient to patient as well. One of the benefits of being medically trained while listening is I understand what the oncologists are doing. I understand their treatments. I understand what's behind them. I can act somewhat as a translator for patients, but the most important thing is that I understand medically where they are, and then more importantly, I can understand where they are individually, where they are mentally, where they are emotionally, and also where they are physically. The referrals that I get are, for patients can really vary. I have had patients come meet me who said, "Oh my goodness, I've been dying to meet you. I've been really hoping that we have a chance to work together." I meet patients who say, "Well, I don't necessarily want to be here, but my wife or my husband suggested that we meet." And then I've had patients say, "My oncologist told me to meet you, and I don't have any idea really why I'm here, and I don't really have any desire to be here." we almost invariably are able to put our time to good use. The thing that it comes with treatment goals, as a medical doctor who can listen and then help with treatment goals, clearly patients want as their goal to beat cancer. But there are also interesting varieties of goals that patients can have. Patients want to know how they can continue work while going through cancer treatment. Patients want to know how they can go through treatment and still be the best spouse they can be, the best parent they can be, the best grandparent that they can be. And so this gives patients an opportunity to really talk through what's going on in their lives along with what's going on with them medically. And it can be extraordinarily helpful. Another thing that we talk about with patients who are new to cancer is what's happening in terms of their family, right? And cancer, as we physicians and treatment team members know, is not just a single diagnosis. A diagnosis for a patient is a diagnosis for the whole family, and spouses and parents and grown children and even teenage children can all play various roles as caretakers with patients. And so really getting a good understanding of not just where the patient is with this new diagnosis, but understanding where the patient's whole family is with this new diagnosis can be extraordinarily helpful for patients. And I can make recommendations for not just my patient, but also for patient family members. Maybe the individual patient would like therapy, or maybe a family member can benefit from counseling. Cancer Family Care is a group that I make a lot of referrals to. They are not a UC entity. They are a independent group that has offices throughout Southwest Ohio and Northern Kentucky. And they offer a wide variety of options for cancer patients. One of those options is individual and or family counseling. And so it's not unusual for me to be able to not just sort of meet with my patient, but maybe meet with the patient and the patient's spouse, so get a firm understanding of what's going on, not just with cancer, but in the marriage. And then to be able to make referrals to Cancer Family Care, where therapists there will meet with individuals or with couples going through the cancer journey, or even families. One recent referral I had was for a mother and her husband, the mother going through cancer, the husband really suffering alongside her in terms of how it's affecting him. And then they have two preteen children. And so they've been able to, as a group, have the opportunity to go to Cancer Family Care and have family therapy. One of the values of this that I find extraordinary is that patients don't necessarily know how to talk to family about their cancer, about their feelings about cancer. Sometimes they feel that the time that they have with their kids, they want to be able to spend as a parent. They don't necessarily want to have every day be discussions about the cancer. Cancer Family Care and family therapy allows patients to be able to have those discussions in a set time and place, and allows them to be able to not only open up channels of communication, but to be able to have more quality time when they are together at home. I met one patient for the first time yesterday. She has advanced pancreatic cancer. She has two grown children in their mid-20s, and she has had pancreatic cancer for 3 years that just progressed. And in that time, she's never had face-to-face discussions with her grown children. Even though she's wanted to, she's not known how. Even though they've wanted to, they've not necessarily known how. And when I talked to her about Cancer Family Care, she was elated to have the opportunity to be able to meet with someone who is going to allow the four of them, she and her husband and her two grown children, to be able to have an opportunity to talk through their feelings, their thoughts and feelings about cancer. Go back that slide again. There's one other interesting referral that I've made. I didn't list this here. It's a group called caringbridge.org. Caringbridge.org is a fabulous site. It's a service that allows folks to be able to write about their cancer journey and share it with selected members, their family and their support network. I really like this because it allows, say I talked to a patient I met for the first time last week. She's not sure how to communicate with her friends and family. She also gets tearful every time she talks about her cancer journey. So consequently, she doesn't call her brothers and sisters. She doesn't call her close friends to talk about it because she gets tearful every time. Caringbridge.org allows her to write out what she's going through and then allow them to read it. I have another patient who is very, very popular on Facebook, but she says she's inundated by well-wishers. She gets 30 or 40 texts every morning, and she says it's impossible to answer all those texts. It's hard to tell the same story over and over again. And she also feels it's rude not to respond. And so we talked about CaringBridge as an opportunity for her to be able to have a set story so that she can refer them to her narrative on caringbridge.org as opposed to having to respond to individual Facebook messages, individual texts, etc. What about a new cancer diagnosis for those of us, that are professionals, right? So as you well know, a lot of Americans have their identity firmly planted in their job. Ask any doctor about that. When you become a cancer patient, what does that do to your job? What does it do to the good things that having a job provides, right? I mean, we saw in the keynote speech this morning how important volunteering, how important work can be to your own well-being. It can be extraordinarily difficult, especially with aggressive, severe cancers that require aggressive treatment. It can be very difficult to go from a functioning, independent individual to someone who is dependent on their treatment team, dependent on their treatment, and whose treatment may make them no longer able to work. And so being able to talk with patients about where they are in that role is extraordinarily helpful for some patients. In the second phase, that I sort of work with folks, when I meet folks, I might meet someone who's already been in treatment for 2 or 3 months and is struggling, sometimes mentally and emotionally, sometimes physically, oftentimes both. So I don't offer myself up as sort of a replacement for the oncologist in terms of treatment, symptom treatment. But I am able to sort of bring a set of tools alongside that works oftentimes quite well in conjunction with oncologists. Oncologists tend to have sort of a set toolbox with respect to nausea, insomnia, pain, neuropathy, hot flashes, say in women going through breast cancer and looking at early menopause. And what a psychiatrist can bring is sort of an additional set of tools for each of these problems and more. So I'll talk a little bit about, mostly about anxiety and depression, but medications that I use that are psychotropic can help with some of these more physical symptoms, the nausea, insomnia, and pain, for instance. Depression is a very real part of cancer diagnosis, cancer treatment, and cancer even in remission. And so I bring kind of the standard set of tools that a psychiatrist does for treating those. I don't necessarily look at sadness in the form of cancer in the context of cancer treatment as a depression per se, or as an opportunity for medications. But I oftentimes meet folks going through cancer treatment who have a history of depression, have a history of anxiety, and their treatment, their diagnoses, the professional and familial and physical impact of all of those can exacerbate depression and anxiety. So I offer the traditional antidepressants, but there are a few antidepressants in particular that can be of use. Mirtazapine is also known as Remeron. This is a medication that I've used. It's a bedtime antidepressant that is also good for anxiety. We take it at bedtime because it has a sedative quality to it. It also has a secondary side effect of appetite stimulation, so it can be quite useful for folks who are in chemotherapy treatment who are experiencing nausea and decreased appetite. Tricyclics are the TCAs. This is an older form of antidepressant. These are also taken at bedtime because they're good for insomnia. And they're also used by neurologists, psychiatrists, primary care physicians for musculoskeletal pain, and can have some benefit also with neuropathy. Neuropathy being a common side effect with some of the chemotherapy treatments. As far as anxiety, we have the standard tools of benzodiazepines, and oncologists are quite familiar, of course, with benzodiazepines and will prescribe them for patients who are experiencing anxiety. They're also good for treating insomnia. And for folks, say, with brain tumors like GBMs, glioblastoma multiforme, they can have some mild anti-epileptic effect as well. There is risk, though. These do have addiction potential. Benzodiazepines, the most common being, say, Ativan, Valium, Xanax, Klonopin, and they are central nervous system depressants, right? So I don't want to treat someone's anxiety, but keep them sedated through the day. I don't want to give them something that can act as a depressant. So I use these sparingly and with full disclosure and discussion with patients. Antihistamines such as Benadryl can be used for anxiety. And gabapentin is an FDA-approved treatment for generalized anxiety disorder. Gabapentin is also a medication that we use for neuropathy. So that's an option for dual treatment there. Olanzapine, the brand name is Zyprexa, is a medication that I use sort of as a little bit more powerful tool than mirtazapine. It can be used in the evening to help with insomnia. It has powerful anti-nausea effect. It's a medication that we also use for bipolar depression outside of the cancer setting, and so can be useful for treating anxiety, depression, as well as the physical symptoms as well. Dr. Chaudhry and I had a patient who had an amazing response to Zyprexa. She's really responded very well to an extraordinarily anxious treatment course. Also, we use anxiolytics, anxiety medications, for folks who experience what's called scanxiety, where people can be relatively very well treated in terms of their anxiety, but as their MRI dates or their PET scan dates approach to check for the progression of cancer, or to see how they're responding to treatment, those scan dates can represent a really monumental time for them, and folks can have a hard time, sleeping the night before. Some folks will report feeling anxiety about scans 2 or 3 days ahead of time, or even a week or two ahead of time. And so sometimes anxiety treatment is just focused to that period before their MRI or their PET scan. The third group of patients I work with are folks that I meet and they've already been diagnosed, they've already been through treatment, they're in remission. This is a really fascinating phase for folks. And some will say this is the hardest part of their journey. It's remarkable how many folks I meet in this phase who say, you know, I got diagnosed, it was terrifying, I hated the treatment, it was brutal, I didn't like chemotherapy, I didn't like radiation, I didn't like the pain, I didn't like the nausea, I didn't like the disability, I didn't like taking time off from work. But the whole time I was going through that, I had a mission, right? I knew exactly what I needed to do. I needed to beat cancer. I needed to get to this point where I am in remission. This is the promised land, right? And they get to the promised land and it's not what they expected, right? One of the things, the first comment I put there, congratulations, you made it. I've had patients describe how once they reach remission, the really robust support system fades away. All the friends are glad. They say, hey, congratulations, you made it. The casseroles stop coming to the house, the texts, the emails, the Facebook messages. It's not that they don't wish the patient well, but they sort of view the patient's cancer as over, right? And it's like back to normal and congratulations. Patients don't necessarily, not all patients miss all the communications, but they do suddenly, by and large, feel like they're more alone, they're less supported. Add to that the fact that there are potential long-term mental and physical effects of cancer treatment. Chemo brain is a phrase that you hear quite a bit. It's quite real. It's not agreed upon exactly what that means. And for different patients, it means different things. Some patients notice they just don't feel as sharp as they used to. Some patients notice that their ability with detailed memories is not as sharp as it used to be. Some patients feel like they need to sleep more. Some patients feel that their sleep is less beneficial. And if they've had surgery and radiation, there are obviously potential physical impacts that can be permanent. Neuropathy can be a permanent impact. Taste. Patients can lose or have this altered their sense of taste and smell during treatment. And that can be an extraordinarily upsetting event for them in terms of their carrying on life where their foods are, the foods don't taste the way they used to. So we're meeting patients who have sort of changed bodies and changed minds, but also changed priorities. And I can't tell you the number of times I've met folks who say, I'm 50 years old. I've been through cancer treatment for the last 3 or 4 years. I had a job that, that I liked and, my family. Now I've got my time back. I've got my family back. I've got my health back, but my interest in my old job has gone. I can I understand I have changed priorities in terms of what I need from my work, from what I need from my life, from what I need from my family, and helping patients negotiate those changes is extraordinarily wonderful to be able to discuss with them what those goals are and how to put them into place. They also have changed relationships. I hate to say it, but I have met a number of patients whose spouses have left them in the process of cancer treatment. It's sort of, one version is, this isn't what I signed up for when we got married. And so having altered marriages, altered relations with friends, family members, and support system can be very impactful. And patients always live with the fear of recurrence, even though they're in remission, even though they have their checkups. A lot of patients will really suffer with that, from that fear. COVID has made a really big impact in terms of how we treat. And so what I do now, I do a mix of in-person, video, and telephone appointments. I prefer in-person and video to the telephone. Patients, of course, are now facing isolation more than ever, and this can be very difficult in treatment and in remission. So we talk about the impact that's made. The last thing I want to share with you is a little bit of data about the model that we have. We have what's called a co-located model. That means that I am in my own office in the hematology oncology clinic. We're not collaborative in the true sense of the word. And there is an excellent model for collaboration set up by Dr. Jesse Pham at the University of Washington's Fred Hutchinson Cancer Research Center. Our goal with Michelle Kirshner and Dr. Erickson and the rest of the cancer survivorship crew at UC is to be able to impose a true collaborative model where we're meeting together about patients. We are setting goals together, and patients are able to come in to see their oncologist, but also be able to meet an entire team in the same location. We're trying to do that at the Barrett Center. This last slide talks about the difference that psychiatry can make. Under a true collaborative model, this slide looks at 8 centers, cancer centers, that adopted a collaborative model. The percentage of folks who had a 50% or greater improvement in depression over 12 months are the green bars. Look at the improvement in terms of depression through cancer treatment compared to usual care. Usual care are the blue bars, and usual care means, hey, you have cancer, I'm your oncologist, I'm sure you're struggling, good luck with that. Maybe go see a psychiatrist out in the community if you can. And referrals for psychiatrists, even pre-COVID, were, could be 2, 3, 4 months away. And patients are, juggling all kinds of appointments and difficulties anyway. Going out and hunting down a psychiatrist on top of that is sometimes work that patients are either unwilling or unable to do. So you can see that if we offer a true collaborative model, that we can have an enormous impact on the quality of life, mental health and physical health of our patients. All right, thank you very much. Anybody has any questions, please, I'll be more than happy to answer them.